the axial muscle system. All right. So the muscles of the trunk, essentially, and particularly the abdominal muscles. All right. So the abdomen has multiple layers of muscle. You know, the thorax up here has the ribs for support and protection. But the abdomen and its contents don't really have any bony protection. You know, they have the lumbar spine in the back and then the floating ribs that come around just a little bit. But most of the protection of the abdominal contents is actually by the abdominal muscles. So there are three discrete layers of muscle. There's the external, the internal, and then the transverse abdominal muscles. And I have some videos here to show you that. But each of these layers, the fibers run in different directions. So because of that, there's a great deal of strength. You know, the abdominal muscles are quite strong, and they serve two roles. One is to move the trunk, you know, so that we can bend at the waist and we can laterally flex to both sides. But also the abdominal muscles are important in breathing, particularly in forced expiration. In other words, when you're talking, singing, playing a wind instrument, anytime that you're blowing against pressure, it's your abdominal muscles that are actually making that happen. And then also they have that important role of protecting the contents of the abdomen from injury. So we have the three layers around the sides here, and then right in the middle of the abdomen is the rectus abdominis muscle. This is the classic six-pack muscle, and it gets that appearance because there are tendons that divide this one muscle into multiple parts. So this is all one muscle, as you'll see in the cadaver lab probably next week, but there are these tendons that separate different bellies. So the rectus abdominis has these tendons that cross it. All right. So it's all about fiber direction. The easiest way to identify which muscle you're talking about, there we go, is by the direction that the fibers are going. So the outermost layer is the external oblique, or the external abdominal muscles. Their fibers run this way. So they run in a kind of V shape, pointing towards the navel. So that's this way. The next layer down, the internal obliques, they run in the opposite direction. So the external obliques point down, the internal obliques point up at kind of an angle. So the arrow or the V points up at the sternum. And then deep to that are the transverse abdominal muscles, and they go across. So that the fibers are across the body's long axis. And then in the middle, the rectus abdominis fibers, they go straight up and down. So the easiest way to identify abdominal muscles is with fiber direction. And we'll look a little bit at that in lab next week, too, as you start looking at some of the models, preparing for then the muscle practical exam that's coming. So let's watch some videos of these abdominal muscles.
The origins of the rectus abdominis muscles are from the pubic symphysis and the pubic crests. The insertions are to the xiphoid process of the sternum and the costal cartilages of ribs 5 through 7. The rectus abdominis muscles flex the vertebral column anteriorly. Rectus abdominis muscles also increase intra-abdominal pressure for abdominal breathing, as during childbirth. They are innervated by the intercostal nerves.
All right, so you're going to see some common themes in the abdominal muscles, and that is that they can move the trunk or they can increase abdominal pressure. So essentially, you know, when you do a sit-up, this rectus abdominis muscle is flexing your trunk. However, if the back muscles were to pull back on that rectus abdominis muscle, you wouldn't move forward. Instead, your abdomen would just compress. You know, that muscle would essentially push the contents of your abdomen up into your chest, which is how you sing or play an instrument or blow up a balloon. So you'll see that depending on what the back muscles are doing, you'll either see movement at the trunk with the abdominal muscles, or you'll see an increase in abdominal pressure, like they mentioned, like for childbirth. All right. So that's the rectus. This is the external oblique.
The origins of the external obliques are from ribs 5 through 12. The insertions of the external obliques are to the linea alba via its aponeurosis, the pubic crests and tubercles, and the iliac crests. Acting bilaterally, the external obliques support and compress the abdomen and flex the vertebral column anteriorly. Acting unilaterally, the external oblique laterally flexes and rotates the vertebral column to the opposite side. Due to the compressive effect on the abdomen, the external obliques raise intra-abdominal pressure and assist in forced expiration. They are innervated by the intercostal nerves.
All right, so this is the outermost oblique. Mostly it's on the side. So the external abdominal oblique is very much, it starts in the back and comes around the side. Here in the middle, this big white area, the rectus abdominis is inside this white sheet, and that's called an aponeurosis. An aponeurosis is just where many tendons have kind of joined together into a flat sheet. So these broad, flat muscles of the abdomen, they end in these broad tendons that are called aponeuroses. All right, so that's the external oblique. Here's the internal oblique, and there again, you can see that here in the center is a wide aponeurosis, but the muscle itself is sort of off to the side, and the fibers point up. So the internal obliques point towards the sternum, and the external obliques point down towards the navel. All right.
The origins of the internal obliques are from the thoracolumbar fascia, the iliac crests, and the inguinal ligaments. The insertions are to the linea alba via a broad aponeurosis, the pubic crests, and ribs 10 through 12. Acting bilaterally, the internal obliques support and compress the abdomen, raise intra-abdominal pressure, and flex the vertebral column anteriorly. Acting unilaterally, the internal oblique laterally flexes and rotates the vertebral column to the same side. Due to the compressive effect on the abdomen, the internal obliques assist in forced expiration. They are innervated by the intercostal nerves.
So just like the external, the internal, when it operates on just one side, so the left or the right, it pulls the trunk over to the side and creates lateral flexion. And because the fibers are not parallel with the trunk, it also creates rotation as well. So you'll see that all of these abdominal muscles share some of the same motions. All right. Oh, I guess I don't have a... The other one is the transverse abdominis, but I don't have a movie of that. And its fibers run this way. So they'll go right straight across. So the rectus goes this way, the internal oblique points up, and the external oblique points down. All right. The last few little muscles of the axial muscle system are part of the pelvic floor, also called the perineum. Like you've seen in lab, when you look at the bony pelvis, there's an opening at the bottom. But obviously, the contents of our abdomen do not fall out. The reason for that is that opening is surrounded or covered by a floor of muscle tissue that we call the perineum. Now, I'm not going to ask, you don't have to know any of these muscles, but it's just sort of the principle of the thing. So the bony pelvis is here, and what fills that hole are all of these different muscles. Also of interest is that in both the male and the female, all the muscles are the same, even though the genitalia are different. So we call that the pelvic diaphragm and the urogenital diaphragm. Together they make up the pelvic floor. All right. Okay, so this is kind of from last time. Of the following muscles of the head, which one wraps around the orbits? Oh, wait, I didn't bring my tablet up here with me.
I know, I was about to say I can't log in.
Shoot. Okay, well, we'll do the questions a little differently then. All right. So which one wraps around the orbits? Okay. The orbicularis muscles are the ones that are round. Orb is round, so orbicularis is round. So we have an orbicularis oculi and an orbicularis oris. So the oculi is around the eyes, ocular, oculi, and the oris is around the aura, or the mouth. So the correct answer here would be C, the orbicularis oris. The nasalis is a muscle of facial expression. It lets you wrinkle your nose so you can elevate your nostrils with your nasalis muscle. The temporalis muscle is one of the chewing muscles. It's found on the side of the head, and its tendon passes through the zygomatic arch and down and inserts on the mandible. And then the masseter muscle is the large square muscle on the side of your face that is important in chewing. All right, we'll just skip it. We got plenty to cover anyway. All right, so that's the axial system. The appendicular system is muscles that move the arms and legs. And we divide those in, first there's the upper limb and the lower limb, so we'll look at the two separately. And then we can look at what the muscles do as the next layer of organization. So we're going to start with the muscles that position the pectoral girdle. So remember, the pectoral girdle is the scapula and the clavicle, and together they attach the arm to the trunk. And there are a number of muscles that position those bones. So position the scapula, position the clavicle to put the arm in the right position to do whatever it is we want to do. So we have those muscles. Muscles that move the arm, so that's the humerus. Muscles that move the forearm and hand. And then the extrinsic and intrinsic muscles of the hand. So the muscles that move the fingers, essentially, are found there at the end. And then in the lower limb, the pelvic girdle doesn't move. So we don't have muscles that move the pelvic girdle around because it's all rigid and bony. But we do have muscles that move the thigh, so that's the femur. Muscles that move the leg, that's the calf. In anatomy terms, the leg is from the knee to the ankle, and the thigh is from the hip to the knee. And then we have, just like with the hand, we have extrinsic and intrinsic muscles of the foot that move the toes and the foot itself. All right, so first we'll just look at the trunk. So most of what you see muscle-wise on the trunk are actually appendicular muscles. Not in the abdomen. Here, these are muscles that are part of the axial skeleton. But all of these muscles up top and these down here are actually going to move the arms and legs. So most of the large muscles on the trunk are actually there to move the arms and legs. And these are very large and powerful muscles. So some of the largest muscles in the body are these earliest or most proximal muscles of the appendicular system. All right. So let's look at a few of those. So we have the broad convergent muscle, the pectoralis major here, the deltoid muscle, which sort of creates the curve of the shoulder. Underneath the pectoralis major muscle, we have a number of other muscles that either move the arm or the pectoral girdle, as we'll talk about. And then if we look at the back, we can see the large, flat trapezius muscle, and then the huge latissimus dorsi muscle. Now, in the human being, the latissimus dorsi doesn't get used in the same way as in our four-legged friends. One of the reasons that this huge muscle exists is it's a running muscle. If you think about a dog or cat that's running on all fours, this is the muscle that powers the running motion of their front legs, is the latissimus dorsi. Now, for us, we don't walk around on our hands anymore, so we use it for other things. But it's in some ways, in the human, the latissimus dorsi is a lot larger than it needs to be for what we do with our arms, but it's an evolutionary artifact. And then the gluteus maximus at the back end. Now, as you go from proximal to distal, what you see is the muscles get smaller, there gets to be more of them, and they have finer and finer control. So here, in the large muscles, like the trapezius and the latissimus, very powerful, but not very precise. But as you move down the arm or as you move down the leg, you get more and more muscles that are smaller and smaller. So that by the time you get to the hands, you have tiny little muscles that can perform very precise actions. So there are few muscles proximally, and there gets to be more as you go down. All right, so our first group are the muscles that position that should say pectoral girdle, not pelvic girdle. Sorry, correct that in your notes, please. So the pectoral girdle being the scapula and the clavicle. So probably the most important of those muscles is the trapezius muscle. And in a lot of the pictures in this muscle chapter, they have used this routine. It's not that the left and right side of the person are different. This side is superficial, and then on this side, the trapezius has been removed. So you can see where they cut it here and then here. And they do that just to show you what the next layer of muscles down is, just so that you're not confused. So the most superficial of these pectoral girdle muscles is the trapezius. It attaches to the spine of the scapula here, and then it attaches to the spinous processes of the vertebral column in the back, as well as to the posterior part of the skull. So the trapezius can perform lots of different actions, but the best one to think of is it stabilizes the scapula, so that as we carry things or throw things or whatever, the arm moves instead of the scapula moving, and the trapezius is important for that. We also have and then underneath those in the back, we have three muscles. The levator scapulae elevates the scapula. It also supports the scapula so that the arm moves instead of the scapula. And then we have the rhomboid muscles, rhomboid major and rhomboid minor. A rhombus, maybe you remember from geometry, is a parallelogram that's sort of off to the side. And these muscles have that sort of parallelogram shape, so they're called rhomboid muscles. When these muscles contract, the scapula rotates and is pulled towards the vertebral column. So, when you go to put your elbows behind you, those rhomboid muscles are pulling the scapula in towards the spine so that the arm can rotate backwards. And then we have the serratus anterior that pulls the scapula in the opposite direction of the rhomboid muscle. So it's going to pull the corner of the scapula this way, out and around. And then in the front, we have the, so in the front we have the pectoralis minor, which really is more of a muscle of the arm. So the positioners are the pectoralis minor, the serratus anterior, which pulls it around, the rhomboid major, and then the levator scapula, and then, of course, the trapezius being the big one in the back. All right. So let's look at that trap.
The trapezius is the large trapezoid-shaped muscle located in the posterior thorax and neck. It may be separated into three groups of fibers: superior, middle, and inferior. The origins of the superior fibers are from the external occipital protuberance, the superior nuchal line, the ligamentum nuchae, and the spinous process of vertebra C7. The insertions are to the lateral 1/3 of the clavicle and acromion of the scapula. With the origin fixed, the superior fibers elevate the scapula gliding it toward the skull. The superior fibers also laterally rotate the scapula upward. With the insertion fixed and the muscle contracting on one side only, the superior fibers laterally flex and rotate the head and neck to the opposite side. With the insertion fixed and the muscle contracting on both sides, the superior fibers extend the neck. The superior fibers are innervated by the spinal accessory nerve.
So that's a classic example of how muscles can do more than one thing. So if the head is fixed, the scapula goes up, but if the scapula is fixed, the head goes down. Same muscle, same contraction. It's which side of the muscle moves and which side doesn't. And that, of course, is controlled by the other muscles that are involved in that motion. The antagonist, for example, will determine whether it's your head that moves or the scapula that moves.
The origins of the middle fibers are from the spinous processes of vertebrae T1 through T5. The insertions are to the medial border of the acromion and the superior lip of spine of the scapula. With the origin fixed, the middle fibers adduct the scapula. This is a gliding movement toward midline. The middle fibers are innervated by the spinal accessory nerve. The origins of the inferior fibers are from the spinous processes of vertebrae T6 through T12. The insertion is to the tubercle of the spine of the scapula. With the origin fixed, the inferior fibers depress the scapula, gliding it inferiorly. The inferior fibers also laterally rotate the scapula upward. The inferior fibers are innervated by the spinal accessory nerve.
All right, so busy muscle, huh? The trapezius has these different parts, and depending on which part is contracting and what other muscles are doing, there are all kinds of motions of that scapula. And remember, the scapula is what attaches the humerus then to the rest of the body. So the scapula positions the top part of the arm so that the other muscles of the arm can participate in whatever action is necessary or needed. All right. So those are the pectoral girdle muscles. All right, so muscles that move the humerus or the upper arm. These are all, well, not all, but many of these are very large and powerful muscles. Again, in some ways, maybe more powerful than they need to be for most of the things that humans do. But since we inherited our muscular system, from four-legged animals, there is we carry these big muscles around with us. All right, so in the front is the pectoralis major, and then the deltoid muscle off to the side. The deltoid muscle, its primary role is to abduct the arm. So abduction up to the level of the shoulder, and then past that, you have the trapezius that's doing the work. And then underneath the pectoralis major is the smaller pectoralis minor, which is not in our picture. That's weird. But the pectoralis minor is underneath here too, but I don't have a picture of it. And then this is an interesting view here. You have to look, see how the ribs have been cut away. What you're looking at here is the front of the scapula. Okay, so I wish I had my skeleton up here, but I don't. So you have the rib cage, and then the scapula sits along the back of it, right? Well, on the front side of the scapula, but the back side of the ribs, is a large flat muscle called the subscapularis, which is right here. So on the front side of the scapula is this triangle-shaped muscle that attaches the scapula to the humerus. And then if we go around to the back, we'll see the deltoid muscle again, the latissimus dorsi that comes up and around, very large muscle that moves the humerus. And then underneath those, we have the rest of the muscles of the scapula. So we have the supraspinatus, the infraspinatus, and then the teres minor. So these three muscles of the scapula, together with the teres minor, form what is called the rotator cuff, which I know I've mentioned when we talked about the shoulder joint. And they get their names based on their position on the scapula. So like the subscapularis It's called that because it's on the back of the scapula. So sub is back. The supraspinatus and infraspinatus are named according to their relationship to the spine of the scapula. So the supraspinatus is above, and the infra meaning below, is below the spine of the scapula. And then the teres minor, teres just means round. So those four muscles, and the mnemonic is, it sits, S-I-T-S. Subscapularis, infraspinatus, supraspinatus, and teres minor. You do need to know the muscles of the rotator cuff. That's why it's in a big blue box here, so that you'll be sure to commit that to memory. All right. So let's look at the pectoralis major.
The pectoralis major is the large superficial muscle of the arm located in the anterior thorax. It may be separated into two groups of fibers, superior or clavicular, and inferior or sternocostal. The origin of the superior or clavicular fibers is from the anterior surface of the medial one-half of the clavicle. The insertion is to the lateral lip of the intertubercular groove of the humerus. The origins of the inferior or sternocostal fibers are from the anterior surface of the sternum, the costal cartilages of ribs 1 through 7, and the aponeurosis of the external oblique muscle. The insertion is to the lateral lip of the intertubercular groove of the humerus. Acting as a whole, the key actions of the pectoralis major are medial rotation and adduction of the arm. Medial rotation is a movement during which the anterior surface of the arm turns toward midline. Adduction is a movement in a medial direction toward the mid-sagittal plane. The pectoralis major also assists in extending the arm at the shoulder from a flexed position.
All right, so pectoralis major. This one is latissimus dorsi.
The latissimus dorsi is the large triangular-shaped muscle of the upper limb, which has an extensive origin from the posterior thorax and abdomen. The origins of the latissimus dorsi are from the posterior lip of the iliac crest, the spinous processes of vertebrae L5 through T7, and ribs 8 through 12 via the thoracolumbar fascia. The insertion is to the intertubercular groove of the humerus. Latissimus dorsi extends the arm at the shoulder. From a state of flexion, it moves the arm to an anatomical position or to a state of extension, and beyond this to a state of hyperextension. It also adducts the arm by moving it in a medial direction toward the mid-sagittal plane, and medially rotates the arm by turning the anterior surface of the arm toward midline. Latissimus dorsi is innervated by the thoracodorsal nerve.
So pushing down on the thing that's your latissimus dorsi's action, is to extend the shoulder. And remember, for the shoulder, this is flexion and this is extension. So latissimus dorsi is pushing the arm down towards the side. All right. We're going to skip the deltoid. This is the rotator cuff one, I think.
The rotator cuff is a term used.
All right, so this is the last movie for a little bit, but this is an important one.
The group of muscles and tendons that stabilize and reinforce the glenohumeral joint and assist with the angular and rotational movement of the humerus.
This one's a little darker.
All four muscles combine at the humeral head by way of tendons and form a cuff over the joint, hence the name rotator cuff. The rotator cuff is comprised of four muscles: the subscapularis, the supraspinatus, the infraspinatus, and the teres minor. The subscapularis muscle originates on the anterior portion of the scapula within the subscapular fossa and inserts on the lesser tubercle of the humerus. This angle allows the subscapularis muscle to provide medial rotation and prevent the humeral head from sliding upward out of the joint as the arm is raised. The supraspinatus muscle originates on the posterior surface of the scapula, above the scapular spine, within the supraspinous fossa, and inserts on the most superior aspect of the greater tubercle of the humerus. This position provides the supraspinatus muscle with the proper angle to abduct the humerus, and more importantly, prevent downward dislocation from the joint when the arm is relaxed or when carrying weight. The infraspinatus muscle originates on the posterior surface of the scapula, below the scapular spine, within the infraspinous fossa, and inserts on the greater tubercle of the humerus. The infraspinatus muscle rotates the humerus laterally and supports the subscapularis muscle by preventing the humeral head from sliding upward when the arm is raised. The teres minor muscle originates on the axillary border of the scapula and inserts on the greater tubercle of the humerus, just below the insertion of the infraspinatus muscle. The teres minor muscle provides for external rotation of the humerus and stabilization of the joint. Although each rotator cuff muscle is capable of providing some type of movement of the arm, their main function is to keep the humeral head centered within the glenoidal cavity, while more powerful muscles lift the arm. Keeping the humeral head centered within the cavity requires that the muscles be in the same plane as the head of the humerus. In addition, the location of the muscles in relation to the joint minimizes the upward pressure against the acromion, a bony projection from the scapula, which forms the top of the shoulder.
All right, so very important muscles there, the rotator cuff. And just like we talked about, the shoulder is a different kind of joint. You know, because it has so much flexibility, it needs muscles to support it. You know, it's not like the knee that holds itself together or the hip that holds itself together. The shoulder requires constant muscle activity for the arm to stay in its proper position on the scapula. All right. So one of the reasons that rotator cuff injuries are so common is because anytime you're using the shoulder to do a thing, you know, whether it's a pitcher or a rower or a weightlifter, there's a lot of force and stress being placed on those relatively small muscles that have to hold that humeral head in place. So rotator cuff injuries are very, very common. All right. So moving down into the arm, the muscles that move the forearm and hand originate either from the scapula, the humerus, the radius, or the ulna. So we have different groups here. We have our elbow flexors. So the bicep brachii is probably the most famous of those to flex the elbow. But the reality is that the brachialis does more of the work than the biceps does in normal flexion. So as you bend your arm, really it's the brachialis is doing most of that work. And then so there's the brachialis underneath the bicep. And then the brachioradialis comes up from the forearm, and it too is an elbow flexor. And then in elbow extension, here we have the triceps brachii, so the triceps is an elbow extensor. And then a very small little muscle right at the elbow called the anconeus muscle. All right. And then at the wrist, we have flexion and extension at the wrist. So flexion is down towards the palm side. Extension is up, is the other way. And we have multiple muscles that do this. Now, the muscles of the forearm have the longest names of the muscles that I've asked you to learn. And in the past, we didn't cover the muscles of the forearm, but because carpal tunnel issues are so common and hand issues are so common, we had to add those in for the various board exams that you all, that many of you will take. So you get to learn these long names. Now, but before you panic, they sort of make sense. So like this one, extensor carpi ulnaris. Extensor tells you what it does, extends the wrist. Carpi tells you where it does it. So extensor carpi is extension of the wrist. And then ulnaris and radialis go with which bone they're by. So the extensor carpi ulnaris is the extensor on the ulna side, and then the extensor carpi radialis is on the radial side. And then a few of these muscles get yet a fourth name, and that's to describe them in relationship to other similar muscles. So there's a longus and a brevis. In other words, there's a long one and a short one of the extensor carpi radiali. Now, these pictures, muscles you can't learn very well by looking at pictures because they're very three-dimensional structures. So what we're going to be doing in lab for the next, I think it's 3 weeks, is you're going to be looking at our models that we have down there. And I think it'll be much, much easier for you to start to visualize these various muscles once you get into lab. All right, so we have those 3 wrist extensors. We have 3 wrist flexors. So we have a flexor carpi radialis and an ulnaris, so we have one on each side. And then we have, well, 80% of people have a palmaris longus, which is sort of in the center. And then, of course, at the forearm, we have pronation and supination. You know, we can spin the hand as well as extend it and flex it. And the muscles that do that are found deep in the forearm, and that's the pronator teres, the supinator, and the pronator quadratus. And there again, you'll see better images of those, or you'll see those better when we get down into lab. All right. So let's look at an elbow flexor. This is the bicep.
Biceps brachii is the large two-headed flexor muscle located in the anterior compartment of the arm. The origin of the long head is from the supraglenoid tubercle of the scapula. The origin of the short head is from the tip of the coracoid process of the scapula. The two heads insert by a common tendon onto the radial tuberosity and by the bicipital aponeurosis, which blends with the deep fascia on the medial aspect of the forearm. Biceps brachii flexes the forearm at the elbow supinates the forearm, and weakly flexes the shoulder. It is innervated by the musculocutaneous nerve.
All right. So that's the bicep. I think, yeah. Here's the tricep. So this is elbow extensor.
Triceps brachii is the large extensor muscle located in the posterior compartment of the arm. It has 3 heads of origin: the long head, the lateral head, and the medial head. The origin of the long head is from the infraglenoid tubercle of the scapula. The origins of the lateral head are from the posterior and lateral surfaces of the superior 1/2 of the humerus. It is located both superiorly and laterally to the radial groove. The origins of the medial head are from the inferior 2/3 of the medial and posterior surfaces of the humerus and is located inferiorly to the radial groove. Together, the 3 heads insert onto the superior and posterior surfaces of the olecranon process of the ulna. Triceps brachii extends the forearm at the elbow. It is innervated by the radial nerve.
All right, so classic elbow extensor. We're going to skip that one. All right, then we get down into the forearm, and we see the muscles that move the hand and fingers. So the muscles that move the fingers, we divide them into extrinsic and intrinsic muscles. It turns out that most of the muscles that move the fingers are not actually in the hand. They're in the forearm. And you can feel that. You know, if you hold your forearm and wiggle your fingers, you're going to feel all those muscles moving around in there. And it's because the muscles that move the fingers are primarily in that forearm region. So we have muscles that flex the fingers and thumb, and then we have muscles that extend the fingers and thumb. So the flexors are found on the palmar surface of the forearm, so the larger, rounder area. And then the extensors are found on the top of the hand side of the forearm. So if we look down into that forearm compartment, we'll see flexor digitorum superficialis and profundus. Superficialis means superficial. In other words, it's on top when you go to look at it. Profundus means that it's the next one down, so it's the deeper one. And then we have the flexor pollicis longus. Pollicis is thumb. So this is a flexor of the thumb, and we call it longus because there's also a short one called the brevis. So we have a long one and a short one, longus and brevis. And then for extension, we have the extensor digitorum. A digit is a finger or toe. So the extensor digitorum and then the extensor digiti minimi allows you to stick your pinky out all by itself. And then for the thumb, we have some additional motion. So we have the abductor, because the thumb can cross the hand, so that's abduction. So we have the abductor pollicis longus. And then we have extensors of the thumb, the longus and brevis. So an extensor pollicis longus, extensor pollicis brevis. All right. Now on the flexor side, all of these tendons of these muscles, you can see the muscles are here, but they have these long tendons that go out to the fingers. Well, we have a bunch of these tendons that all have to go to different places in the hand. So on the flexor side of the forearm, so the palmar side of the hand, we have what's called the carpal tunnel. And what this is the bones of the wrist form a kind of arch along the top. So from the top of the hand standpoint, there's an arch like this. And then underneath, traveling through that arch, are all of these tendons for the flexor muscles that allow us to wiggle our fingers with great precision. So all of those things have to go through a very narrow space. So here are the wrist bones. This is the palmar surface of the hand. This is the back surface of the hand. You can see this arch. Here are all those ligaments, or tendons rather, in here. And then to make matters worse, also traveling through this same space is a nerve, and that's the median nerve. The median nerve innervates the thumb and the first 1.5 finger. So the index finger and half the middle finger are provided by the median nerve. So the reason that you've all probably heard of the carpal tunnel before is because this is sort of a weak spot in human anatomy. Because there are all these things that are going through a narrow space, and they're all in motion. So like when you're typing, for example, particularly if you're typing in a bad position, those tendons are sliding back and forth all the time. And just like everywhere else in the universe, if you do that, you're going to get friction. And when you get friction, you get swelling. More swelling means now these tendons are bigger, so they're rubbing together even more, and you can kind of see that it's kind of a cascade effect. The problem gets worse and worse and worse. And then to make matters worse, because there's a nerve traveling through there too, when these tendons start to swell up, this nerve gets pinched. And when the nerve gets pinched, it either hurts or it causes numbness. So people with carpal tunnel syndrome will complain of pain or numbness in their thumb, index finger, and half of the middle finger, particularly when they have been busy using that. So one of the solutions for that is to cut this the top part of the arch. So here's the bony part. This part of the arch is a tough ligament. And one of the treatments for carpal tunnel syndrome is to cut that ligament so that there's more room for all of these tendons to pass from the muscles out to their site of effect out in the fingers. So the carpal tunnel is right about here on this side. All right. So flexors and extensors of the fingers. And then when we get down into the hand itself, you can see the tendons that are coming from the forearm here. But then there are also muscles that are actually found in the hands themselves. So the intrinsic muscles of the hands, the lumbricals allow flexion, at the metacarpophalangeal joint, so you can make an L with your hand because of the lumbricals. That's another mnemonic. So L for lumbrical makes this action possible. And then we have abduction, adduction, so we can spread our fingers apart and we can pull them together. Those are accomplished by the interosseous muscles. And then we have opposition of the thumb and pinky. We can pull our pinkies across our hand and our thumb. And those are the opponens muscles. So the opponens digiti minimi moves the digiti minimi is always pinky finger. Smallest digit is digiti minimi. And then the opponens pollicis is for the thumb over here. So the hand is a very complicated place, and I don't ask you to know. I'm not sure. You might not even need to know any of these, but consult your list. Those of you going into occupational therapy, you someday will get to learn a great deal more about the forearm and hand than we're going to cover in here, because that's a big part of what OTs do is work with hands. All right. Well, let's call it right there for today, and we'll pick up next time with the